So acknowledging on this beautiful Friday morning that I am a white settler immigrant on the land of the Coast Salish peoples. This is an unceded ancestral territory of the Musqueam, the Squamish, the Tsleil-Waututh nations, and the Métis Charter community of the Lower Mainland region. And all of you, wherever you are, to acknowledge and ponder and commit to learning more about the land and the peoples that you're on, so that we can share it and be custodians together. Next slide. So Province-Wide Rounds is a collaboration between UBC Division of Nephrology and BC Renal. We gratefully acknowledge the support of all of our industry partners, as well as all of the health authority people and personnel that support both the education, learning, and projects that help to improve the care of our patients living with or at risk for kidney diseases. Next slide. So this morning we have Dr. Barbour and Dr. Sinead Stoneman and for a much awaited overview of a new treatment option for lupus. Just a little bit about Dr. Barbour. He's a clinical associate professor at the University of British Columbia in the Division of Nephrology, based at Vancouver General Hospital, and provincial chair of the BC GN network. He is a member of multiple international groups, including, I believe, the chair of the International IgA Nephropathy Group, as well as participating in clinical trials and doing a lot of research with administrative data sets, including our very own BC GN registry. Dr. Sinead Stoneman is currently a GN fellow in the Division of Nephrology and BC Renal. She completed her medical school at University College Dublin and internal medicine and nephrology through the Royal College of Physicians of Ireland. And before she moved to BC, she was completing a master's in leadership and innovation in healthcare through the Royal College. She is specifically looking at the use of urinary CD163 and ANCA vasculitis through the University College at Cork, in addition to the work that she's doing with Sean. So with that introduction of our esteemed colleagues in the GN world, I'm going to pass it over to Dr. Stoneman and Dr. Barbour. Over to you guys.
Thank you, Adira. Give me a second just to share here. Do you want to? Okay. Perfect. Thanks. So welcome everybody. So today we're going to talk about Belimumab treatment for lupus nephritis. This has been sort of a long time coming. We have a wide group of people we've invited to the presentation today. So we have, as per usual, the nephrologists and allied care individuals through nephrology in the province. But we've also invited the rheumatologists that are interested in this to attend, because although Belimumab coverage will be through nephrology prescriptions, and I think it's quite important that we collaborate with our rheumatology colleagues, especially as we're sort of starting to learn, which patients should be treated with this disease. And so there might be a good opportunity to have collaborative discussions with your rheumatologist involved as well as to whether a patient may benefit or not from Belimumab. This is a sort of relatively newer and more complex funding mechanism through BC Renal. So we have actually representation from GSK, which is the makers of Belimumab, as well as the Monarch program, which I'll go through later, which supports patient access to Belimumab if needed. And then we also have representation from BC Renal in case there's any logistical questions that come up at the end. So the general framework of our presentation today is going to be that Sinead will start off with a background on the literature supporting Belimumab therapy for lupus nephritis. And then at the end, I will go over the logistics of how exactly you go about applying for, getting funding for, and then prescribing Belimumab for your patients. And then hopefully there'll be quite a bit of time at the end for some open discussion if anyone has any questions. So with that, I'm going to hand over to Sinead, who's going to go over the first part, which is the background on Belimumab. So thanks.
So thanks very much. So thinking about the background of lupus nephritis, many of us are familiar that approximately 50% of all patients with lupus develop lupus nephritis, and about 30% of patients living with lupus who are white develop lupus nephritis. 60% of patients living with lupus who are either Black or Hispanic develop lupus nephritis, and maybe 40 to 80% of patients living with lupus develop lupus nephritis who are Asian. And the 5 and 10-year cumulative incidence of end-stage kidney disease is between 11 and 19%, but this depends on the histologic class and the population sampled. And we know that people with lupus who have lupus nephritis die earlier than the general population, and also those without lupus nephritis. And the standardized mortality ratio increases with development of chronic kidney disease and also the development of end-stage kidney disease. So it has huge impacts on patients. And I suppose, one of the abilities that we have in British Columbia is to look at the outcomes of patients in our province. And through the BCGN registry, we could look at all adult patients diagnosed with biopsy-proven lupus nephritis in the province over 21 years from 2000 to 2020. And of 581 patients, the mean age was 38.7 years, 85% were female, and the median eGFR at biopsy was 86 mils per minute, with a median proteinuria at biopsy of 2 grams per day. Over time, however, this cohort had a 20-year risk of ESKD of 35% and a 20-year risk of death of 30%. And given the time period of the study, this treatment group received, the treatment the group received would have been cyclophosphamide and steroids or MMF and steroids. So why are outcomes so bad during an era treated with MMF and cyclophosphamide, which is our current standard of care? And I suppose on the one hand, you have this form of standard of care therapy clearly not doing enough to prevent end-stage kidney disease and diseases being undertreated. While on the other hand, young people are dying prematurely, some from complications of ESKD, but others from infections and cardiovascular disease and suffering from complications of immunosuppression. And this is really consistent with the published literature. So then thinking about belimumab and BAFF, BAFF is a member of the tumor necrosis superfamily of cytokines that induces B-cell proliferation and differentiation, and is expressed by numerous cells and exists in both membrane-bound and soluble form, and the biologically active soluble form is enzymatically cleaved from the cell membrane and can bind to one of 3 receptors on B cells. And newly formed B cells are dependent on BAFF for survival, whereas plasma cells and memory B cells are less susceptible to BAFF inhibition. But following B cell activation, there is B cell proliferation and differentiation to resting memory cells and antibodies secreting plasma cells. Where belimumab comes in is a recombinant, fully human monoclonal antibody that inhibits the biologic activity of soluble form of BAFF. Belimumab blocks the binding of soluble BAFF to its receptors on B cells, thus inhibiting the survival of B cells, reducing differentiation of B cells into immunoglobulin producing plasma cells. Most of us are very familiar with rituximab, and belimumab has some similarities and some differences with rituximab. Rituximab is chimeric and binds to the CD20 antigen on the surface of B cells and stimulates cellular cytotoxicity and complement-dependent cytotoxicity, resulting in apoptosis of CD20 positive cells, whereas belimumab affects the interaction between soluble BAFF and B cells and results in reducing the proliferation and survival of B cells. Both of them have no interaction with commonly prescribed medications. Hepatitis B reactivation has been reported in both. Infection events are similarly common. Infusion reactions are less with belimumab compared to rituximab because it's a fully humanized monoclonal antibody. Then thinking about evidence, this really comes from the phase 3 BLISS-LN study. So we thought it would be important to kind of review this study because it's a while since it's been published. And it was a phase 3 international multi-center double-blind placebo-controlled randomized trial that assessed the efficacy, safety, and tolerability of belimumab as an add-on to standard of care in adult patients aged 18 years or over. It was conducted at 107 sites in 21 countries. To be eligible, patients had to be antibody positive with positive ANA or double-stranded DNA and fulfill the ACR diagnostic criteria. A kidney biopsy had to be performed within the previous 6 months and had to demonstrate class 3 or class 4 with or without class 5 or pure class 5 lupus nephritis. And only patients showing active and chronic lesions were enrolled. And in addition to the kidney biopsy findings, patients had to have an EGFR greater than 30 and a UPCR greater than 1 gram per gram. Exclusion criteria were previous failure of both cyclophosphamide and MMF, dialysis within the previous year, receipt of cyclophosphamide induction in the previous 3 months, treatment with any B-cell therapy, including belimumab or biologic investigational agent in the previous 12 months, severe active CNS lupus or an EGFR less than 30 at screening. Patients received belimumab or placebo on day 1, day 15, and day 29, and then every 28 days until week 100. The standard induction therapy had to be initiated within 60 days of initiation of belimumab or placebo. An IV cyclophosphamide or MMF was used for induction. And for maintenance, the IV cyclophosphamide group received azathioprine, while the MMF group continued to use MMF for maintenance. Methylprednisone was given at the discretion of the investigator, and high-dose corticosteroids were used during the trial, and patients were recommended to receive RAS inhibition and hydroxychloroquine. And there was also strict criteria about the tapering of prednisone, that patients had to taper to 10 milligrams per day by week 12, and it was considered a treatment failure if they were not at 10 milligrams per day or less by week 24, and they couldn't exceed this dose through week 104. This is the baseline characteristics. It was a predominantly female population and an Asian population treated in Asia. Median time from lupus nephritis diagnosis was 2 months. Probably lower ACE-ARB use than we would have in BC, but apart from the GFR, relatively similar to the population of lupus patients we're treating in British Columbia. It was predominantly pure class 3 or class 4 lupus nephritis, and 16% had pure class 5. And the baseline UPCR was 3.2 grams per gram in belimumab and 3.5 grams per gram in placebo. 797 patients were screened and 448 patients were randomized, resulting in 223 in the treatment and control groups. Analysis was by modified intention to treat. The primary efficacy endpoint was defined as an EGFR no more than 20% below the pre-flare value and a urine protein creatinine ratio of less than 0.7. And for the complete renal response, the UPCR had to be less than 0.5 and the EGFR could be no lower than 10% of the pre-flare value. This looks at the primary efficacy renal response, and we can see that starting at week 20, more patients in the belimumab arm had a primary efficacy renal response. And similarly, for the complete renal response, more patients in the belimumab arm had a complete renal response from week 44 onwards. This is time to a composite renal or death event. And patients who have received belimumab had a statistically significant lower risk of renal-related event or death compared to placebo, and this was mainly driven by proteinuria and reduced impaired kidney function events in the belimumab group. At week 104, significantly more patients in the belimumab group had a primary efficacy renal response. They also looked at a subgroup analysis according to stratified randomization criteria, and The point estimates for cyclophosphamide or MMF induction were similar, and the confidence intervals were wider for the cyclophosphamide group because there were significantly many more patients in the MMF group compared to cyclophosphamide. Adverse events overall were common, and infection was the most common treatment-related adverse event in both groups. But overall, no difference in events between groups, and you just see that they're very common adverse events reflecting how the population and the amount of background immunosuppression they receive. There was also a 28-week open label extension that patients could enter at week 104. This obviously was a single arm, and there was also no restrictions on additional medications. So it has some limitations in terms of interpretability. And you can see that about 50% of patients completed the study to week 104, and many of them entered the open label extension. Mainly the baseline characteristics were similar to the overall background population, but the baseline UPCR and EGFR was quite impressive. But this reflects this was a survivor cohort who had managed to get to the end of the trial without suffering from complications of lupus or treatment, and were then able to continue on in the trial. Somewhat unsurprisingly, the longer you treat people, the more adverse events you see in the belimumab group, particularly with opportunistic infections. But overall, the numbers were small. And post hoc analysis using the more stringent double-blind criteria for the primary efficacy renal response showed that in placebo to belimumab, the proportion of patients with the primary efficacy renal response was 54%. This figure shows the cumulative probability of the primary efficacy renal response and complete renal response, and that these were sustained in the open label through open label study at week 28. And I suppose you can also see that at week 28 in the belimumab group, there's an uptick at week 28, reflecting that if patients could continue treatment, they were more likely to have a primary efficacy or complete renal response. They also looked at some key kidney outcomes, particularly looking at EGFR slope and more validated clinical trial endpoints such as 40% and 30% EGFR decline. And this subgroup analysis was performed to evaluate whether the response to therapy differed by histologic lupus nephritis class, and showed that the primary efficacy renal response and complete renal response was mainly driven by patients with proliferative and class 5 lupus rather than class 5 alone. The point estimate is less than 1 for class 5, but there's again wide confidence intervals reflecting that this was a small subgroup. And this is time to kidney related event or death, and events were defined as the first incidence of death, progression to end-stage kidney disease, or doubling of serum creatinine from baseline or kidney-related treatment failure. And overall, the risk of having a kidney-related event or death during BLISS-LN was significantly reduced by belimumab, and the point estimates were consistently in favor of belimumab across classes of lupus nephritis and background therapy. This is time to first flare from week 24, and belimumab reduced the risk of lupus nephritis flare by 55% compared to placebo. And consistent with the overall population, a reduction in the risk of a lupus nephritis flare with belimumab was evident across both standardized treatment groups and across all lupus nephritis classes. In both the on treatment and on study analysis, and this really reflects whether someone was still on treatment at week 24, belimumab reduced the risk of having a 30% and 40% decline in EGFR at week 104 relative to placebo. I mean, those who work in nephrology are familiar with that this is a validated clinical trial endpoint, so it gives us confidence that this has a benefit in terms of reducing risk of end-stage, kidney failure in the long term. This is primary efficacy renal response and complete renal response modified by baseline proteinuria, and the effects of belimumab favoring the primary efficacy renal response and complete renal response were driven by the response in patients with a baseline proteinuria of less than 3 grams per gram. And there may be some reasons for that, if you have a threshold of having to have a UPCR of 0.7 or 0.5, if you start off with a higher proteinuria, it may take longer to get to that threshold, because the time to events and the reduced flares this was not seen. And this is the results of the time to kidney-related event or death across baseline proteinuria. And again, this was consistent with the overall population, suggesting that the positive effects of belimumab treatment on the reduction of the kidney-related events or death were consistent across both low and high proteinuria levels. They also looked at whether there was differences between whether the patient was de novo or had recurrent lupus nephritis. And overall, the proportions of patients who achieved primary efficacy renal response and complete renal response were greater with belimumab in both de novo and relapsed lupus nephritis. And they appear to be numerically better in the de novo group, but the caveat to that is that the exclusion criteria probably excluded those with more resistant recurrent disease. But I suppose overall there was no significant difference whether you had de novo or recurrent lupus nephritis, which is encouraging for treating patients. I might skip some of these slides in the interest of time. But also there was also one final subgroup analysis that's maybe important to people working in BC, that they looked at an Asian subgroup, and the efficacy and safety of belimumab in this subgroup was consistent with that of the overall trial. So gives us confidence that this is an effective medication in this subgroup. Some parts of the trial generated some discussion when it was published. Particularly, they changed the primary endpoint during the study. They had a comment to an editorial that this was done after or before unblinding, so they didn't know that the results or preliminary results when they made this change. And they made this change based on data from the EuroLupus study that was released in 2015 that showed that including microscopic hematuria actually reduced the efficacy of proteinuria at 12 months as being a predictor of long-term renal outcome in patients with lupus nephritis. And this, including urinary red blood cells, which had been part of their initial endpoint, undermined the predictive value of proteinuria at 12 months in predicting long-term renal outcomes, and that was the rationale for changing the primary endpoint. There's been a lot of debate about baseline proteinuria, and hopefully I showed that even though the primary efficacy renal response and the complete renal response was in the proteinuria and class 5 subgroup, was not as effective compared to proteinuria less than 3 or the pure class 3 or class 4. There are probably disease reasons for this, and also the use of the threshold criteria that class 5 takes longer than 2 years to maybe reach this threshold. And this was an editorial by Liz Lightstone, who said that, similarly, that this lack of effect on nephrotics in patients may be explained by time required for proteinuria to decrease to meet the specifications of this 0.7. And the lack of effect on class 5 may be explained by different disease mechanisms. And that I suppose we can also be reassured in that in the class 5 subgroup analysis, there was reduced flare and reduced time to the composite kidney endpoint. Some other people said that, the use of ACE and ARBs was low, which it was. And because if people started an ACE or ARB after randomization, but before week 24, this was not a treatment failure. And they wondered whether this could have biased the results if there was inequality post-randomization. And the authors responded to that and explained that there was no difference after randomization. Reflecting different interpretations of the data, there are some minor differences between EULAR, ACR, and KDIGO guidelines. EULAR and recommends that for patients with active lupus nephritis, combination with belimumab should be considered. And if that patients should be treated for 3 years, and if they receive belimumab as part of their induction treatment, they should continue on this drug. Could I go give some more nuanced recommendations and mixed recommendations that are patients with class 3 or class 4 lupus nephritis with or without a membranous component can receive belimumab with mycophenolate or low-dose IV cyclophosphamide as a potential treatment option. And this may be preferable in patients who have had repeated kidney flares or a high risk of progression to kidney failure due to severe chronic kidney disease. And if patients are I suppose, somewhat similar to the EULAR guidelines, that if they're treated with the triple regimen, they can continue with this triple regimen as maintenance therapy. There is some difference with the ACR guidelines, and this has only been released as a kind of preliminary guideline. But they do make a recommendation that patients with more than 3 grams per gram of proteinuria patients receive a triple immunosuppressive regimen that contains mycophenolate plus a CNI, but that you would consider belimumab for extrarenal manifestation. So there is a difference there. And there is BC Renal has released a frequently asked question for prescriber guides, and a lot of this information is contained within that, but based on pharmacokinetic and pharmacodynamics data, even though the trial included only intravenous infusions, belimumab is licensed as a subcut preparation, and many patients find this preferable compared to infusions. No dose adjustments are necessary, and subcutaneous injections into thigh and abdomen resulted in similar belimumab exposure. This is kind of recommendations from the package inserts that it's not recommended in patients with severe active CNS lupus. Live vaccines are contraindicated, and that patients should be pre-screened and monitored during treatment for depression and suicidality, although in BLISS-LN there was no difference in the reported adverse events for depression and suicidality. It came from earlier trials. It's currently not recommended in pregnancy, and women of childbearing potential should use contraception for at least 4 months after treatment. There hasn't been any human studies of it in breast milk, but in monkeys, belimumab is found in breast milk. So there should be shared decision-making about women if they're using belimumab during breastfeeding, and obviously not using live vaccines in children who are being breastfed. So then I will hand over to Sean about approval procedures for belimumab through BC Renal.
Okay, thank you, everybody. With that background in mind, I'm now going to go through the process of accessing belimumab through BC Renal. Some of you may not necessarily be aware, and certainly I wasn't aware of the details of how a drug actually gets to a provincial formulary. The belimumab story is actually a little bit interesting because it's the first time, at least, that the GM committee had to address an issue basically from start to finish through the drug approval process. So first, GSK submitted to Health Canada for an indication for belimumab for lupus nephritis. Now, it had an indication previously for the treatment of extrarenal lupus, which wasn't really universally funded, but there was an indication for that. After Health Canada gave the indication, which was based on an analysis of the efficacy outcomes of the trial, it then subsequently went to what was formerly CADID and is now the Canadian Drug Agency. And the question that is raised at the CDA is, should provinces fund the medication? So it's a different question than whether or not a drug should have an indication through Health Canada. So CDA then made some recommendations around criteria for funding and price points for funding, which then went to something called the Pan-Canadian Pharmaceutical Alliance, which is basically an organization of different provinces that come together to negotiate with the drug company in order to leverage scale across the country instead of having different negotiations in different in different provinces. And this was the first time that BC Renal participated for a GN medication at a PCPA negotiation. So BC Renal participated in that negotiation, and once that negotiation was successful, it then came on BC Renal to develop a local implementation plan in British Columbia. So the reason why I'm going through this is I want to go through the CADIC criteria a little bit, because some of you may be aware of criteria in different provinces, and some of the provinces have taken these criteria and applied them without any changes at all. And I'm going to try to point out some of the areas that I actually disagree with the CADIT recommendations, and how this will factor into how our criteria in BC are a little bit different. So CADIT suggested that belimumab could be considered in patients who are diagnosed with class 3, 4, or pure class 5. We have to consider that what CADIT did to make these criteria is essentially strictly apply the inclusion criteria and the outcomes of the clinical trial. And we know that clinical trials, are designed to try to identify a homogeneous group that can show an efficacy response. They're not necessarily designed to guide how treatment should be used in the real world. And I think we've already seen some data now that there's perhaps a little bit more equipoise as to how efficacious belimumab might be in patients with pure class 5. So we're going to come back to that a little bit when we see the BC Renal criteria. There was also a recommendation that belimumab needs to be started within 60 days of patients starting induction therapy. And so where does that come from? That comes from the inclusion criteria of the trial, which required this. And again, one of the reasons for this is that some of the failures of previous trials have been potentially because they included too heterogeneous a group of patients who are perhaps too far into different treatments. And so the goal here from a trial point of view was trying to identify a homogeneous group of people who had just recently started therapy. The problem is that sometimes 60 days is not very long for you to sort of get your ducks all in line as you're treating a patient, and to determine whether a patient actually is adequately responding to current immunosuppression, and whether they may actually even need the addition of belimumab. So our thoughts were that if you require this very short time window, you may actually inadvertently sort of force physicians into applying for and starting treatment with belimumab in patients without actually knowing if they really need it, which may have the unintended consequence of unnecessary over-immunosuppression. And I think we do need to consider that, because we know the burden of immunosuppression in lupus patients contributes to multiple bad outcomes, including cardiovascular disease, including opportunistic infections, including cancer outcomes. So there is a definite need to avoid over-immunosuppression in patients who are likely going to do very well otherwise. The trial did not include groups that we may want to consider in clinical practice, right? So the trial wasn't interested in looking at patients that had previously failed cyclophosphamide and MMF and had resistant disease, or patients that had severe acute kidney injury and GFR had declined to less than 30. Now, in the real world, though, patients who have resistant disease may very well be a group of people you want to treat with belimumab, because without the additional benefit of an add-on therapy, it's quite likely that those patients are going to progress to end-stage kidney disease. It's just that they were not represented in the trial and will probably never be represented in the trial. There may be observational data that comes out down the road, but they were not included in a trial, and most trials, in fact, don't include this group of patients. Similarly, patients with more severe disease who have an acute decline in GFR to less than 30 may be another group of patients we really do want to treat with belimumab, which needs to be distinguished from patients who have CKD and scarring and start off with a baseline GFR of less than 30, in whom the benefit of an expensive therapy may be, substantially more modest. They also comment on what is required for renewal of belimumab after 12 months. And what they required is that steroids be reduced down to 7.5 milligrams per day by 12 months. They also required that the GFR be, sorry, this is skipping around here. Give me a sec. That the GFR be within 20% of baseline or above 60, and that the proteinuria be less than 0.5 grams per day by 12 months. So what they are effectively requiring is that patients have to achieve the primary efficacy renal response outcome of the trial by 12 months in order to continue therapy. This doesn't necessarily stand up to reason. The trial did not require in any way that patients achieve this outcome by 12 months. If you recall, the trial outcome was assessed at 2 years. And they also suggest that for subsequent renewals after 12 months, you have to demonstrate that patients are still in remission. So the consequence of this is that funding was dependent on achieving the outcome of the trial at 12 months, whereas the trial actually went to 2 years. And they're actually suggesting that patients who achieve remission stay on drug indefinitely. So this is not necessarily the way we would align our usual sort of approach to treatment, in which, if patients are showing some improvement at 12 months but haven't necessarily entered remission, you may actually want to continue the drug for an additional 12 months to see if you could achieve remission. Whereas patients who clearly achieve remission at 24 months and don't have some other complicated reason for needing long-term therapy, that may be a group of people in whom you actually want to stop belimumab to avoid, again, unnecessary long-term immunosuppression. So with all that in mind, I'm going to now go over the criteria that we have for through BC Renal, and we actually have 4 different categories of applications. These are very, very subtly different. So what we have is one category that we've termed adjunct treatment for class 3 or 4 disease in a GFR greater than 30. This is basically meant to be the criteria for your usual patient who would likely meet the inclusion criteria of the trial that you're thinking about your sort of routine add-on therapy. But we have 3 other groups that we are considering separately. The first is patients who have an acute kidney injury in a GFR less than 30. The second is patients with pure class 5 disease. And the final class group is patients who have resistant disease. And not all of these patients may have been represented in the trial, but we've done our best to come up with what we think are clinically meaningful criteria that allow you to access therapy in patient groups that may not have, or were not in the trial and may never be included in clinical trials. The important thing is that these applications are very subtly different. If you just look at them superficially, you may think that they're quite similar, but there are very small differences throughout the initiation, 12-month, 24-month, and subsequent criteria. So it is quite important that when you go to renew your applications at 12 months and 24 months and at time points thereafter, that you use the same application form that you would have used to initiate treatment in the first place. Because if you don't, you may find that you run up against problems of exclusion criteria to continue the drug. And so it's really important that you use the same form throughout the entire course of the patient's renewal. So there's a patient support program called Monarch. What this does is it was designed to help secure funding through private insurance, which may not necessarily be relevant once we have our BC Renal formulary coverage. But it also does other things that are quite helpful in prescribing belimumab. It helps find infusion clinics and it coordinates the IV infusions for you so that you don't need to do that through medical short stay or other infusion clinics. It will help switch patients from IV to sub-Q injection, and it will help give patients a teaching around doing home injections. This application form also constitutes the prescription for belimumab. So once you fill out the form, you don't need to actually send a different prescription anywhere else. However, if we want to take advantage of this program, we do need to find ways to integrate the Monarch program into our usual BC funding process, which might be new, and we haven't done this for previous medications. So what's the process you need to go through? So first, we need to make sure that patients are under the care of a nephrologist, registered in the BC Renal Health Authority renal program, and the patient is registered in PROMIS. So this is very similar to access for all other drugs through BC Renal, in that it has to be prescribed by a HARP-associated nephrologist, and the patient needs to be in PROMIS. The first step you're going to do is you're going to fill out the BC Renal application form. You're going to send it in and then wait for approval. Once you get your approval letter back, you then fill out the Monarch form and send to Monarch the Monarch application form as well as the BC Renal approval form together. By doing that, Monarch will know that the funding for this medication is through BC Renal, and they won't go trying to hunt for other sources of funding for your patient. Monarch will then coordinate the IV infusions or the sub-Q teaching if required. And then every 12 months, you're going to need to renew your application. And you basically go through the same process. Fill out the form through BC Renal, get the approval form back, send it into Monarch. So I'm going to go through some of the details on the forms a little bit. We don't have time to go through, every little small detail, but I'm just going to try and point out how some of these details are different between the different categories. So this is what the form looks like for your usual adjunct treatment. So this is the class 3 or 4 disease with a GFR greater than 30. So this is meant to reflect the usual population that may have been represented by the trial. So, as per usual, you have to tell us what disease they have. You have to tell us what dosing and duration you're applying for. But the maximum approval time is 12 months because you will need renewal every 12 months. So then there's initiation criteria. So these are the criteria you would fill out the first time that you go to get drug approval. So similar to the trial, you need to demonstrate that patients have on a kidney biopsy within 6 months class 3 or class 4 disease. You also need to make a comment that patients have active disease. And the reason for this is we don't want you inadvertently sort of treating patients who have only class 3C, who only have chronic lesions, for example. There needs to be some level of activity. However, there are circumstances in which patients are too sick, to undergo a kidney biopsy. And, in that circumstance, there's an opportunity to justify why a biopsy can't be done and why you think they're having a flare. They also have to have started induction therapy, but we've used a time period of 4 months. So as opposed to 60 days that was recommended by CADIT, we've expanded that to 4 months. And the rationale for that is to give you a little bit more time to see if you can identify which patients are really rapidly responding to your induction therapy and are entering remission and likely do not need belimumab and may actually get harm from over-immunosuppression but not actually incur any benefit. So we're not saying you have to wait 4 months. You don't have to wait 4 months. But what we're saying is you have up to 4 months to make the application, which then doesn't force you to start treatment early in a patient that may not otherwise need it. So the criteria here is someone who has started within 4 months and has not already entered remission. And for this set of criteria, they cannot previously have failed both cyclophosphamide and MMF. So the continuation criteria at 12 months. So if you recall, CADIT required that after 12 months, patients essentially meet the primary efficacy renal response outcome. And we thought that this was not really clinically reasonable, and it wasn't justified by the trial. And therefore, we changed our criteria to just having some sort of soft measures that the patient is doing better. So they can't have started a new immunosuppressive therapy for lupus nephritis because that would mean they're probably not doing or responding very well to belimumab. You have to get the prednisone down to less than 10 milligrams per day, and the GFR has to still be, above our 30 threshold. That's really all that's required at 12 months. At 24 months, though, it does get a little bit more complicated. So the general theme of the 24-month criteria is that patients who do not have an otherwise complex history of lupus who have achieved remission on belimumab should essentially stop therapy at 24 months. However, there are certain circumstances in which you may want to continue belimumab, and so that's what we've tried to outline here. So the criteria for continuing belimumab are that they haven't started an additional rescue medication, their steroid dose is less than 10, their GFR is greater than 30, but I would add the caveat that we do provide a section for saying there are reasons why kidney patients may have slow progressive decline in GFR that is not due to uncontrolled lupus. It may be due to scarring or other reasons, and so there's an opportunity to explain that if required. But in order to continue belimumab, you need to satisfy one of the following 3 criteria. So the first is that the patients have shown improvement in the previous 12 months, but are not yet in remission. So this is an example of a patient, who's shown, in this case, a 25% reduction in proteinuria in the previous 12 months, but they're not quite yet less than 0.7. So this might be a patient that from the extended trial data suggested if you continue treatment a little bit longer, maybe you can actually get them into remission. And so maybe that's a patient population you don't actually want to stop. But because they're showing improvement, they're demonstrating some benefit for the drug, maybe you want to continue it longer. The second group of patients are patients who have a problematic history of maintaining remission on currently available maximum therapy. So these are patients who have achieved their remission. So you're not using belimumab anymore to try to get into remission. You're trying to use belimumab here to maintain remission and avoid disease flare in a group of patients who have already demonstrated that they've had disease flares on the maximum dose of MMF. So I'm not talking about someone flares on MMF 250 milligrams twice a day. That's not a maximum dose. I'm talking about someone who's flared while on 2 grams a day of MMF, and you need to really augment maintenance therapy. that might be a group of patients where you would like to continue belimumab based on the reduction in disease flare data that Sinead talked about. And finally, there might be a group of people, probably not right now because belimumab hasn't been used that much, but as belimumab gets used more and more, there might be a group of people in whom you've used belimumab for maintenance therapy, you've stopped it, and they promptly relapsed very quickly afterwards. In that group, you probably want to continue belimumab as well. And so that's what the idea behind this third category is. But again, patients who have achieved remission who don't have one of these complex histories, the default of the criteria is after 24 months, they would be coming off of therapy. If you do get approval to continue treatment at 24 months, then you would need to renew your application, 1 year later, based again on those sets of criteria. Now, there are different subgroups of patients that we've tried to address here that were not included in the trial. And, these criteria may not be perfect. We may need to modify them over time as we get more experience with them. But what we've tried to do is address this group of patients, which is now patients who have an acute kidney injury and their GFR is less than 30. So the premise here is you have to demonstrate that it is an acute kidney injury, that they started off with, better kidney function that got worse due to active lupus. Patients who have advanced CKD with a persistent chronic GFR less than 30 would not qualify for belimumab therapy. So the initiation criteria, so that's the group with the GFR less than 30. So the reason why it's important to keep using the same form is after 12 months of therapy, for this group, you're going to have to demonstrate some sort of improvement in kidney function. So if the patient was on dialysis, hopefully they've recovered and come off dialysis by 12 months. If they haven't, then you wouldn't be continuing belimumab, after the first 12 months, for example. Another group of patients that we are looking to address is patients who actually have resistant class 3 or class 4 disease. So in this situation, we're looking at patients who have been resistant to all other reasonable therapies for lupus. Now the question is, or sorry, I should say for lupus nephritis. And the question is, what are reasonable induction therapies? So we've listed here MMF, we've listed cyclophosphamide, and we've listed MMF with a calcineurin inhibitor. We have not listed anything about rituximab here. And the reason for that is, rituximab is more controversial in terms of its efficacy. So we're not requiring patients try rituximab before they try, belimumab for resistant disease. And that's just because the strength of evidence is perhaps more controversial for rituximab. It doesn't mean you can't try it, but it's not absolutely required. And finally, we have a group of patients of criteria for pure class 5. So if you recall, the data supporting pure class 5 was perhaps a little bit more controversial from the belimumab study. So based on this, we have CNIs available, for use in patients with class 5 disease. And so our criteria here are more patients who have been resistant to other therapies for class 5, including MMF and including calcineurin inhibitors. I would also point out that there's controversy again between the guidelines as to which patients with class 5 disease need treatment at all. So KDIGO recommends only treating patients with pure class 5 disease who have nephrotic range proteinuria. And that comes from the fact that we, as nephrologists, have a lot of familiarity with membranous nephropathy and the good outcomes that are seen in patients with subnephrotic range proteinuria, whereas some of the rheumatology-based guidelines recommend treating everybody with pure class 5 and proteinuria over 1 gram per day. So that is a very, strong difference. And in fact, if you look at the criteria of BLISS, there are patients who could have gone into the trial with class 5 disease who would not have even met the treatment criteria for KDIGO. So we've adopted the KDIGO guideline approach, which I think is the approach used by most nephrologists in the province, that we treat patients with pure class 5 disease who have nephrotic range proteinuria over 3.5 grams per day. Those are the groups of application forms that we have available. As I said, as we get more experience with them, we may need to update them if we find issues. It was not straightforward coming up with these criteria that made sense, that stayed true to some extent to the trial, but addressed patient populations that we know you probably will want to treat with belimumab. I would like to point out that this was a complex process to go through. There are a lot of people involved to get to the point that we're at right now, where belimumab is, as of today, officially covered by BC Renal. And, there's a whole BC Renal team here that I've listed. And people were involved, at various stages of the way, from developing the criteria, from negotiations with GSK, with putting together the funding that requests to PHSA to get funding for this medication, to sorting out the logistics with Monarch. It was a lot of different moving parts. So I'm pretty happy and proud to say that we now have access to this drug in BC. I'm sure it will take us some time to get familiarity with the drug and to understand, our patient population that may benefit. But with that in mind, I'm happy to take any questions now that anyone may have about, the literature behind Belimumab, or maybe the processes of going through and getting the drug and actually how to use it.
Great. Thank you, Karen Henry. Thank you, Sean and Sinead, for a very comprehensive and great overview. There's a practical question from Dr. Copeland, which is whether or not we'll require a urine ACR to monitor proteinuria, or do we have to do 24-hour urines on everybody?
So the criteria right now are listed in terms of protein excretion per day. The trial used PCR on 24-hour urine collections, so they weren't spot PCRs. The trial outcomes were PCRs on 24-hour urine. I think if you have a PCR of 300 or an ACR of 300, you very clearly do not have proteinuria less than 0.7 grams per day. We haven't stipulated exactly what form of measurement is required, but I think that it stands to good clinical practice that if you have proteinuria that's in the range that you're unsure of, you should probably confirm it with a 24-hour collection, if needed.
Yeah, I'm going to channel my inner Carolyn Stigant and just say, like, from a practical perspective, like, it might be good to not have these plastic jugs and 24-hour urine, et cetera, if it's not essential. So you might want to think about a urine ACR cutoff below which you want a 24-hour, but otherwise it would be okay. Is that fair? Because I think it's a lot of workload.
Yeah, you'd be really surprised the spectrum of spread between 24-hour urine or 24-hour protein excretion and urine ACR values. Like, it's really quite substantial. So, I can tell you that personally, I do not use spot urine tests to make treatment decisions in lupus patients. But of course, everyone knows I love the 24-hour collection anyways. But I think that, this is a really, really important biomarker you're using to make very important treatment decisions. And you do not, in my mind, want variability that's a result of random variation and possibly.
Yeah, so I guess maybe just to make that super clear, that you do want 24-hour urines at
When we
least.
haven't mandated it, I would say, like, you have to use your clinical judgment. I don't think I want to force everybody to do 24-hour urines if we don't have to, but we can try to come up with some common sense criteria. Like, it's pretty clear you haven't met criteria or you have under certain circumstances. If your ACR is 2, it's pretty low.
If you
So I
didn't,
think
yeah.
you're doing good. Yeah. Yeah.
I'm just saying, like, you might want to think of a cutoff. Fareen has his hand up to ask a question. Fareen?
Hi, thanks. Thanks for that, Sean. Quick question. As we're trying to get used, or like you say, familiar with this drug, are you at this stage not requesting to be a gatekeeper to access to this drug? It sounds like we can just go ahead and, I don't want to say trial it for ourselves as general nephrologists, but given that you're the gene expert, I'm sure you're looking at some data with these patients. Are you looking to be a gatekeeper for this, or is there a way of, asking you to review patients without you having to go through formal consultation for some of these patients, or what's your thoughts on that?
Yeah, we have not required that. There is no requirement whatsoever that I see the patients that are treated with belimumab. I don't think that would be feasible. We have a lot of lupus patients in the province. I don't think I'd have the capacity to see them all. I'm certainly happy to informally chat with people as they start to get a little bit used to the medication. And we had a similar situation when we kind of moved over to more rituximab for membranous over a few years. People would tend to chat about it, and I think now nephrologists are far more comfortable treating membranous with rituximab. So I think over time it will become more familiar to everybody. There are a lot of things going on in the background, like Monarch is entering the belimumab data into PROMIS. So we will have records in PROMIS of who's getting the drug, what dosing they're getting, so that we can look at outcomes associated with it, especially for those groups of patients where we're deviating from the trial criteria, right? We want to see, like, are we doing something good for those patients who have resistant disease or class 5 disease? And over time, we will accumulate the data to look at that. But the short answer is no. There's no requirement that I see the patients, but of course, I'm more than happy to chat with you informally if you want. So I think the big message here is don't just feel like you need to start it in absolutely everybody. Some people do really, really well, but some people, their history, right? And you know that they're not going to do well on MMF and cyclophosphamide, and so those are the people where you probably do want to start it a bit earlier.
Great. There's some more questions, but all of a sudden I'm having difficulty. Carolyn also has her hand up.
Yeah, can you hear me?
Yep.
Great. Yeah, thanks, Sean and Sinead. It's super helpful, and definitely have to review this a few times to get some of the subtleties of it. But I'm just picturing myself counseling a patient about I'm applying for this medication for them, assuming it's going to be covered. Sean, do you have any suggestion for how we might counsel a patient? I'm a little uncomfortable with saying you might get it subcutaneous, you might get it IV. A third party is going to arrange for you where you're going to receive this medication. I won't know when they receive it, hence to contextualize the blood work. I think it would help me in comfort going forward, how a sample of how a prescriber would counsel a patient and anticipate that process to unfold.
Yeah. I have to say I'm going to have some familiarity with patient support programs too, for example, through eculizumab, right, which I've been using for HUS or C3G or whatever we're doing. And you do get messages back from them when the patient's getting the drugs.
Okay.
They do communicate with you, the patient started therapy. And so you do know. It does take a lot of onus off of you to make the arrangements. The trial looked at IV. I tend to start patients on IV therapy, and then once they're doing well, if they are getting a little bit more frustrated with the IV infusions, then switch them over to sub-Q down the road, and kind of take it from that approach of starting off on IV. And that way I can also make sure that they're in a controlled environment when they're getting the first infusion. Although infusion reactions are very, very rare, you don't really need pre-medications with belimumab. However, there are patients in the province, and we do know from having studied the incidence of lupus that those of you that work in the Northern Health Authority or the Interior Health Authority, or regions that cover quite rural and remote demographics, there are going to be people who develop lupus nephritis in whom it may not be really all that feasible for them to travel to an IV infusion center on a regular basis for 2 years. So those are people where you may want to consider starting on sub-Q therapy, not because the study did that, it didn't do that, but because the practical implications for your patient is that it just may be too costly or too time consuming for them to thrive, and then they may not, be able to keep up with that, long term. So the process is that I mean, I know it feels like you're taking some control out of your hands, but you're not. I mean, the Monarch program will do the prescription that you wrote on the piece of paper. So you can feel like it's like an oral medication. You've prescribed it, you've given it, it will get sorted out. They will communicate with you and let you know when the patient starts, therapy. The choice between IV and sub-Q is controversial. It was based on pharmacokinetic and pharmacodynamic data. There was no separate study done using the sub-Q dosing. So for that reason, I tend to start on IV therapy, but I work in Vancouver and patients are local and it's a little bit easier. If
Right.
you do have patients that are quite rural and remote, the Northern Island, for example, like maybe consider starting on sub-Q.
There's a comment in the chat about the physician receives documentation post-infusion unless the patient is self-injecting. So I guess that would be the sub-Q is when you would just,
Yes, I mean,
fire
once
and
they're
forget, and
self-injecting,
then,
yeah. Now, there's other factors people have raised about that. I mean, the IV therapy, obviously in the lupus population, it's nice to know your patients are actually getting the drug, right? So if they don't show up for an infusion or it gets canceled, you'll get told about that.
Yeah, for sure.
Whereas the sub-Q therapy, you are relying on them to continue it at home the same way you're relying on them to take the MMF, which sometimes isn't always 100%.
Yeah, and apologies, I missed this. The frequency of administration and also the time over which the IV is administered.
The IV is given relatively quickly. There's a few loading doses, and then it's given once monthly for 24 months, and then the sub-Q is weekly.
Thanks, Sean.
Yeah.
yeah, there's a number of other.
It's all on the application form. Like you don't need to remember it. It's on the application form. You'll see the first few doses IV, and then the maintenance doses. And the sub-Q is a higher dose for the first few, and then a lower dose, and it's all written there.
Great, thank you.
So there's a number of questions in the chat, some of which perhaps we'll take note of and then you can answer. But everyone's thanking you for all the amount of work that you and the team did to get it to where it is. There are a number of questions about safety in pregnancy. And also, I think you answered this, but if you have a urine ACR that's low and a biopsy with class 3 or 4 with moderate activity, should you or could you order this? I mean, what do you?
Yeah. So if you'll notice, we have not included an inclusion, like there's no criteria that you have proteinuria above a certain level, to even get in, right? So there are people who have low level proteinuria that you do a biopsy and they have active disease. But again, I think you need to use your clinical judgment and say, is this someone you really need to use triple therapy in, right? If they have, usually those people have very mild histologic activity, and that's why they have relatively low proteinuria. So again, the theme I'm trying to say is you need to now make, like, this is a classic cost benefit analysis that you
Yes.
need to do in your head, right? You need to say, okay, if I give this person triple therapy with belimumab, I'm going to expose them to more immunosuppression. I mean, there may not have been more serious adverse events in the trial, but we all know that you are adding to the burden of immunosuppression. There is going to be, if you do this in enough people, some sort of risk associated with that. You want to give it to the group of people that you think will actually require that additional immunosuppression so that they can get into remission quicker, more sustained, have less scarring, less CKD progression. So the people who have really mild disease at the beginning, I mean, unless you know something about their history of lupus that makes it problematic, I would say, use some judgment and say, maybe just give them MMF and steroids for a little bit and see how they do. And if all their biomarkers get better, in the first few months, that's the reason for having the 4-month window, is that you can now, take some time to use clinical judgment to decide who should get treatment.
Yeah, and maybe I can just suggest, I mean, this is a privilege to have this drug so easily funded by BC Renal. I think what Sean's saying is, let's be good stewards of the public purse and use this well. It may be worthwhile, Sean, to think about, in the next 3 or 6 months, having a little round table with some cases that have been funded and sort of just review with the community, like, oh, these were all appropriate. Some of these were perhaps less appropriate, that kind of thing, to sort of get people used to and share some of the experiences. Because I think that this could easily be default, everybody goes on this drug. And that's not what you're saying. And I think it's really important that we have some feedback.
Yeah, there's one question I actually want to there's a question about septal prophylaxis. So if you're giving this, on the background of MMF and prednisone, or on the background of cyclophosphamide and prednisone. So you absolutely certainly want to give someone a PCP prophylaxis when they're on that burden of immunosuppression. So I think that is really important to consider as well. And I don't know if there's any other.
Yeah.
I'm just looking through here.
Yeah, I'm just looking. Jen's just saying that you can talk to make sure that you copy the rheumatologist on the Monarch application so that they also know when the drug is started. And there's a few comments from Kim as well as Jen that a lot of people prefer sub-Q.
Yeah. The thing I would mention about sub-Q is it is a biologic drug, which has a higher volume when you do a sub-Q injection. So some patients do find it stings quite a bit when they inject it, but it is, once a week. But you might want to warn them of that. It's, maybe a little bit different than giving insulin, for example.
Yeah.
There's also a question about distributing the slides. Like, hopefully, I think this is being recorded. Maybe
it is. It's recorded.
There's probably
so
a link.
There's a link at BC Renal website, so you can just click on that.
Yeah. So you can maybe watch it again if needed.
Yeah, we're a little bit over time, but it's a big change and it's a huge step forward. And I think maybe getting a report back in the next 6 months, either as a province-wide rounds or more informally as a roundtable discussion, it'd be quite nice to see where we're at in the province.
Yeah, I mean, and I have no doubt that we will be following the financials of this quite carefully. We've budgeted out, we have good data on the number of lupus patients that are incident and prevalent in the province. And so, if it starts to really escalate and its use beyond what we thought, maybe we need to consider, identifying subgroups that we want to restrict this to more. But we'll be following that, quite carefully, which is the benefit of having all the data integrated into PROMIS, where we can do that.
Yeah, no, it's excellent. Okay, well, with that, we are over time, and I want to thank Sean and Sinead for really an excellent and informative presentation, but the whole group, the Pharmacy Services Committee, the statisticians and analysts who were projecting what this would be and cost, et cetera. And, it really does take a village to get this organized like this. And I think we're quite lucky in the province to have this very equitable approach to being able to make sure that everybody gets it. So thank you very much. And you broke 108 people at the highest level were on the line. So congratulations to that. And happy Friday, everybody. Thanks.
Bye-bye.
Bye.